Thank you very much. It's a pleasure to be here. Thank you for the invitation. Yes, I'm from Exeter, and yeah, if you were impressed by the Altos labs, I should have put a picture up of the beach or something, because Devon really is lovely. You should come and visit. We're a lot less productive than those guys, but we have even more fun, I can tell you. So multi-morbidity, you mentioned complexity. This really is, this is complex. I don't really know what multi-morbidity is, and I certainly don't understand what dementia is, and that will become clear through this presentation, which is worrying because this is the focus of my research, really. So multi-morbidity, on the face of it, is a very simple idea. If you have two or more long-term conditions or chronic illnesses, the language is sometimes slightly different, but the basic idea is the same. And you can see here for both men and women, multi-morbidity in these different studies is on an upward trajectory with age. No great surprise there. But what I think is quite surprising is just how common multi-morbidity is. And you can see here by around retirement age, around maybe most people have two or more chronic conditions. Now, for our aging populations, this has huge implications. Now, multi-morbidity, because it's all possible conditions, if you look at something like the ICD-11, these kind of taxonomies of disease, there are literally thousands of conditions. Now, the idea that these might be related to brain health, dementia-related pathology, and so on is not a new one. But multi-morbidity, of course, is really complicated. And there are different families of conditions that we'll all be familiar with. You know, the different types of cancer, different types of cardiovascular disease, and so on, and so on. And they're each caused by a unique combination of genetics, lifestyle, and environment, and that's each individual condition. So when you combine all of that, we really are talking about both high-dimensional data and enormous, almost unfathomable complexity. Now, dementia, we really struggle to explain what it is and come up with something that we can all agree on. Some people will focus on pathologies. So people will talk about amyloid plaques, phosphorylated tau, the hallmarks of Alzheimer's disease. There are lots of other protein abnormalities that cause different clinical conditions, and the role of vascular pathology, stroke and small vessel disease and so on is often neglected, but is certainly important as well. So each individual will have a combination of these pathologies, or they will, if they're lucky, age well and be relatively protected against them. But because we're thinking about multi-morbidity, I was thinking about multi-morbidity in the context of these pathologies themselves. So if multi-morbidity, when we think about all conditions, becomes the norm around retirement age, cerebral multi-morbidity actually becomes the norm at adults who are around 85 years. So multiple disease processes in the brain, but there is a lag, and that lag is interesting to reflect on, I think. Now, you might have then a combination of these pathologies, which gives you, as an individual, a unique clinical presentation. And if this burden becomes sufficiently severe, that spills over. Your cognition declines, you struggle with functional activities, and that is the clinical syndrome of dementia. But in a way, in your own subtle mix, the underlying causes are probably to a degree unique to you. Now, if we combine this idea of multi-morbidity, the upstream risk factors for multi-morbidity leading to these clinical conditions, which in combination drive up the risk of brain pathology, which spills over eventually becoming the clinical syndrome of dementia. That gives us a kind of conceptual model for thinking about multimorbidity and dementia. So UK Biobank is a wonderful resource to really try and dig into this in more detail. And I'll give you a couple of different examples of papers that I've been involved in which approach this in different ways. And our experience with Biobank began with this paper from Ileana Lerida and colleagues, where we realized for the first time that with UK Biobank, we just had the sheer scale of data which would allow us to dig around and think about how things like polygenic risk scores might be able to be combined with different types of data. And in this case, we were interested in the best established risk factors from a lifestyle perspective for dementia. And we were really interested, not whether genetics drove up dementia risk. Of course it did. That was well established. Not whether lifestyle factors drove up dementia risk. Of course they were associated. But whether really in combination they interacted, or was it an additive association? That was the kind of question that we wanted to ask. The data we'd used before were clinical studies with hundreds of participants in, or patients in typically, or they were population-based where there were thousands of participants. But this is, I mean, you know UK Biobank is just on another level. And for the first time, we were able to show that within each genetic risk category, that lifestyle still made a difference. And the people who were particularly unlucky, who had an unfavorable lifestyle and a high genetic risk, you can see that their risk of developing dementia was greatly increased. There was no interaction between these lifestyle factors and the polygenic risk score in UK Biobank, which was quite important, I think, because that suggests, it undermines the fatalism argument that if you were genetically predetermined to have a higher risk of dementia, that maybe there was nothing you could do about it. So that set the stage for us to extend these analyses and to think more about multimorbidity. And with Sinyu Tai from the University of Oxford and other collaborators, we focused next on cardiometabolic multimorbidity. And in particular, we were interested in diabetes, heart disease, and stroke, and how that combination might be predictive of dementia risk. So if you, the reference group is having none of those conditions, and you can see that if you have one of these conditions, it increases your risk of developing dementia. If you have two of these conditions, you had an even higher risk. And for a small number of people who had a stroke, myocardial infarction, and diabetes, their risk of developing dementia was more than 5 times higher. So we're seeing huge, strong signal for, and I think this is a very clear articulation for the merits of thinking about conditions in combination, so multimorbidity in other words. And again, we can stratify this by genetic risk and show that as the number of conditions goes up within low, medium, and high genetic risk groups, it's still there. It's still a very clear pattern of association. Another wonderful thing about UK Biobank is the availability of the neuroimaging data. And neuroimaging studies that were dementia-related have historically been very small in size. Studies like ADNI are very, very widely used. And there's about 800 participants. So even though it's in a subsample within UK Biobank, this is an amazing opportunity for us to look at more directly at brain-related pathologies. And you can see here for hippocampal volume, those with 2 or more of these cardiometabolic conditions had the lowest volumes. Total grey matter volume is a nice pattern there. And white matter hyperintensities, which are more of a vascular mechanism, you can see that increasing with those cardiometabolic conditions. So I think that's an interesting finding in itself, but it also just serves to highlight some of the richness in the UK Biobank data. And the last example I will give is one which is far less focused So if you think about selected cardiometabolic conditions, we chose those because there was such strong evidence for those already. David Ward and our other collaborators, including Kenneth Rockwood, looked at a very large number of conditions in a much less targeted way. And they construct a frailty index, which is literally just the proportion of any of those conditions that you have. So they're equally weighted and combined. And again, you can see those with a high number of health, long-term conditions, they have a much higher risk of developing dementia. This is the proportion of any of these 45 conditions. So they're not ones which have been pre-selected to be relevant to dementia. Now, interestingly, we thought of lifestyle as being an upstream risk factor for multimorbidity. And almost half of the relationship that we'd already identified between lifestyle and dementia risk was mediated by frailty. So it's interesting to start to piece together different elements in that hypothesized causal cascade. And again, we can stratify by genetic risk of developing dementia. But this time there was something interesting. There seemed to be a possible interaction between frailty and genetic risk, where the genetic risk in the low frailty group was far clearer than it started to collapse in this high frailty group. And we think it's probably because the influence of frailty itself is so strong that it's maybe even drowning out some of the difference associated with genetics. So, as we've seen, multimorbidity is the norm, particularly in older adults, and it's caused by this kind of complex mix of genetics, lifestyle, and the environment. And then multimorbidity is playing a really causal, important role in the development of dementia-related pathology, which in turn is spilling over to cause that unique clinical syndrome in each patient. And lastly, just to note that I'm an enthusiastic user of this data, as I'm sure you can tell. And thank you for everyone who's put it all together, and to the patients and participants too. Thank you.